Hello, everyone, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Melissa Hudson, co-leader of the Cancer Control and Survivorship Program. On behalf of myself and my co-program leader, Dr. Greg Armstrong, we are delighted to host a seminar focused on survivorship outcomes. It's my pleasure today to welcome Dr. Kirsten Ness from the Department of Epidemiology and Cancer Control at St. Jude Children's Research Hospital. And now I'm pleased to introduce Dr. Ness. She is a physical therapist and clinical epidemiologist whose research is focused on recognizing, describing, and remediating functional limitations in childhood cancer survivors. She received her PhD in epidemiology from the University of Minnesota in 2004 and subsequently joined the St. Jude faculty in the Department of Epidemiology and Cancer Control in 2006, where she is currently a full member and director of the Human Performance Lab. Dr. Ness has leveraged her extensive clinical experience in physical therapy and advanced training in epidemiology to develop an innovative research program focused on describing the prevalence of and risk factors for adverse outcomes after childhood cancer, with a particular emphasis on physical performance, fitness, and physiologic reserve. Her long-term goal is to utilize knowledge gained from these descriptive outcome studies to develop interventions that prevent and remediate functional loss in childhood cancer patients. She's recently expanded this work in ongoing collaborations with computational biology and laboratory investigators that aim to elucidate the biologic processes potentially responsible for the loss of physiologic reserve in childhood cancer survivors. Dr. Ness has been successful in maintaining continuous extramural support for her research over the last 5 years from a variety of resources, including ACS, NCI, and AICR. I'm pleased to share with you that she's recently assumed the MPI status with me for the St. Jude Lifetime Cohort Study. She's also engaged in numerous leadership roles in the Childhood Cancer Survivor Study and through the Children's Oncology Group Survivorship and Outcomes Committee. Dr. Ness has institutional, national, and international reputation as the go-to investigator for collaboration and consultation in investigations focusing on physical activity and performance outcomes of childhood cancer survivors. She's disseminated her research findings in over 200 publications that have featured significant clinical observations related to physical performance limitations and the functional status of children and adolescents across the cancer survivorship spectrum. So we're delighted that she will share these findings from her research that have informed interventions to prevent and remediate frailty in childhood cancer survivors. Dr. Ness.
Thank you, Melissa, for the kind introduction, and thank you for inviting me to talk today. So today I will briefly reference how the incidence of childhood cancer and survival following a diagnosis of childhood cancer has resulted in a growing population of survivors. Next, I will talk about how frailty can be characterized in survivors and some potential interventions to remediate frailty in survivors who are already frail. Finally, I will conclude with some exciting interventions that have some potential to prevent frailty in young survivors and current patients. These data from the Surveillance Epidemiology and End Results Program indicate that cancer incidence in the United States among children younger than age 20 years continues to increase. Fortunately, improvements in treatment and hospital care have decreased mortality such that 85% of children will survive at least 5 years. There are over 480,000 survivors of childhood cancer living in the United States today. Frailty can be measured or characterized in survivors in 3 ways. First, on a global level as an accumulation of diseases or deficits. Second, on a phenotypic level using pre-specified criteria that characterize physiologic health, where 3 or more of muscle wasting, muscle weakness, slow walking speed, fatigue, or low energy expenditure is considered a frail state. And finally, on a more mechanistic level using measures that signify molecular aging. To talk about deficit accumulation, there is nowhere better to start than to summarize disease burden in the Childhood Cancer Survivor Study, a multi-institutional cohort of over 25,000 5-year childhood cancer survivors diagnosed with 8 different cancer histologies from 1970 to 1999. This rich cohort has data for both survivors and siblings and includes detailed treatment information and data on health status ascertained by self-report in multiple sequential questionnaires. This table shows basic diagnosis, demographic, and treatment information for the CCSS cohort, with 40% of the cohort having a history of leukemia, 30% having a previous exposure to chemotherapy, radiation, and surgery, 56% of the cohort being male, and a mean age at diagnosis of 7 years. Childhood cancer survivors have high rates of chronic disease in young adulthood. These data from the Childhood Cancer Survivor Study show the cumulative incidence of a first-grade 3 to 5 chronic condition rising with time since diagnosis. Even among survivors treated more recently, the 20-year cumulative incidence of at least one grade 3 to 4 chronic condition is still 27.5%. As a comparison, only 4.6% of siblings experience a chronic condition over the same time period. Data from the Childhood Cancer Survivor Study also allows us to look at function in childhood cancer survivors as they age. Functional impairment is 4.5 times more prevalent, and activity limitations 2.4 times more prevalent among survivors compared to siblings. Females experience more functional loss than do males. So moving on to another large cohort study, the St. Jude Lifetime cohort was designed to facilitate longitudinal clinical or in-person evaluation of health outcomes in aging adults surviving pediatric cancer. Participants were treated for cancer at St. Jude Children's Research Hospital and survived at least 5 years following a diagnosis of their primary cancer. The original aims were to study the prevalence and latency of late effects, identify multifactorial predictors of adverse outcomes, develop risk profiles for adverse outcomes across the age spectrum, and use data to guide health screening and risk-reducing interventions. So as of March 2020, 6,005 survivors and 773 controls were enrolled. 5,223 survivors and 736 controls had completed at least one in-person evaluation. Our participation rates reflect the survivors' commitment to the institution and to the oncology team that treated them when they were children. This cohort is just over half male, and 17% identify their race as Black and 4% their ethnicity as Hispanic. Predominant tumor types at diagnosis were acute lymphoblastic leukemia, central nervous system tumors, and Hodgkin's lymphoma, although many other tumor types are represented. This slide shows the data elements collected on study participants as part of medical record abstraction, questionnaire completion, comprehensive clinical assessment, core laboratory measures, diagnostic studies, and cancer screening assessments. In keeping with the original aims of the project, the cohort was evaluated to determine cumulative burden of chronic disease among survivors. Burden of disease is substantial, with the mean number of grade 3 to 5 chronic conditions by age 50 years at 5 per person, a value twice that of community controls. The burden of disease can partly be attributed to therapy, and thus, with some early recognition of treatment-related toxicities, changes in protocol-delivered therapies have changed the types of chronic disease experienced by survivors. This figure shows that among survivors of acute lymphoblastic leukemia treated more recently, the highest prevalence of disease among those 30 years of age are in endocrine and musculoskeletal categories. Infection and second malignant neoplasm are much less common than in earlier eras. Driven by the need to better understand chronic disease differences among survivors and either siblings or members of the general population, particularly because of the apparently early onset of age-related disease among survivors, my lab team looked at aging literature to see if we might be able to identify an underlying phenotype. The Human Performance Lab at St. Jude opened in 2007. We see 35 to 40 patients and survivors a week and have had over 20,000 visits since July of 2010. Initially, our participants were mostly members of the St. Jude Lifetime cohort, but we've expanded our collaborations and now see many children during treatment, both to document the effects of tumor or therapy on function and to provide interventions to prevent functional loss. We do measures in the Human Performance Lab of cardiopulmonary fitness, including vascular testing, autonomic function, range of motion and flexibility, anthropometrics, muscle quality, quantitative sensory testing, neurological integrity, functional balance, and general mobility. In our observations in the early days of St. Jude life, among survivors in their 20s and 30s, we noted that they were physiologically frail, with physical performance values similar to those expected in older adults, like slow walking speed and muscle weakness. In the geriatric literature, physiologic frailty is defined as a loss of physiologic capacity that interferes with normal function. It can be distinguished from disability and comorbidity, and identifies persons vulnerable to adverse outcomes, chronic disease, and mortality. The black line represents typical physiologic decline expected with age. And as one of my staff asked me yesterday, what does that little dot represent? What age am I going to start declining? Well, around age 30. So you start losing physiologic reserve around age 30. So we hypothesize that children with cancer experience early and then accelerated physiologic decline related to disease and or treatment exposures, represented here by the dotted line. If this is the case, then one of our goals is to develop interventions that change the trajectory of this line. So to reiterate, phenotypic frailty or physiologic frailty was first defined by Linda Fried in the cardiovascular health study among individuals 65 to 101 years of age as 3 or more of the following components of fitness: muscle wasting, muscle weakness, self-reported exhaustion, slow walking speed, and low energy expenditure. Those having 3 components were frail, and those with 2 components pre-frail. In an initial analysis, frailty in the St. Jude lifetime cohort among survivors, a mean age of 33 years, was prevalent among nearly 8% of survivors, compared to a rate in the 65-plus-year-old cardiovascular health study participants of 6.2. Remarkably, it was associated with a 2.6-fold increased risk of mortality among survivors only after a 3-year follow-up period. To validate these findings and to examine it in a larger cohort to see if we were correct, we looked at frailty in the CCSS cohort. The rates were slightly lower than those seen in the St. Jude lifetime cohort, but that was likely because we had to rely on self-report. Luckily, in the new expansion of the CCSS, we'll be able to measure frailty in person in a subset of the participants. Nevertheless, even though the rates seemed lower than in the St. Jude lifetime cohort, they were substantially higher than among siblings. So before designing an intervention, we wanted to see if frailty progressed with age in St. Jude Life participants. We invited 1,500 survivors back for a second St. Jude Life visit. These survivors were 18 to 45 years at their first visit. Rates of frailty nearly doubled in 5 years. Baseline frailty was associated with a more than 3-fold risk of death in models that accounted for chronic disease. To better understand what's driving this phenotype and to get targets for intervention, this figure shows the prevalence of survivors who meet criteria for each frailty component. Low lean mass, muscle weakness, and low energy expenditure are problematic, with muscle weakness and low energy expenditure substantially increasing in 5 years. We've been looking at correlates of frailty in the St. Jude lifetime cohort, and this paper from Annalyn Williams, one of Kevin Krull's postdocs, showed that over an interval of approximately 5 years, pre-frail and frail young adult survivors had greater declines in cognitive domains associated with aging and dementia compared to non-frail survivors. And these findings suggest that interventions designed to mitigate components of frailty may also mitigate or prevent neurocognitive decline. Pain, another potential consequence of childhood cancer and its treatment, has been reported by up to 59% of long-term survivors. Pain may impact survivors' ability to engage physically with daily activities, and it may precipitate or exacerbate frail states. In the general population, specifically among older adults, frailty contributes to the development and progression of frail health. So Dr. Tara Brinkman looked at the association between progression or changes in pain and changes in frailty, defining pain based on the questions, how much bodily pain have you had over the past 4 weeks? Or have you been told by a doctor that you have migraines or other severe headaches? And pain interference is during the past 4 weeks. How much did pain interfere with your normal work? So there are 3 main pain groups: those with no or moderate pain, those who had pain without interference, and those who had pain with interference. So you can see that both frailty and pain changed over time. And she found that the relative odds of frailty were nearly 2-fold higher in survivors who either had persistent pain or increased pain, suggesting, again, that interventions to decrease pain might improve outcomes related to phenotypic frailty. In addition to pain, childhood cancer survivors also experience disordered sleep, where sleeping less than 6 hours per night and taking longer than 30 minutes to fall asleep 3 or more nights per week is associated with a high burden of chronic disease. Also likely contributing to frailty is another age-related phenotype, documented even among survivors who are not exposed to cardiotoxic therapies, and that's exercise intolerance. Like frailty, exercise intolerance, defined as a peak oxygen uptake of less than 85% of expected, is associated with mortality in childhood cancer survivors in the near term. After a median follow-up of 4 years, the hazard ratio for death was nearly 4 times higher among those with exercise intolerance when compared to those who did not have exercise intolerance. Now I'm going to shift gears a little bit and show you some evidence of molecular aging in childhood cancer survivors. These data were generated by my colleagues Xiaoming Wang and Mandira Kundu using the data from the St. Jude Life Genomics resource, which is available on the St. Jude Cloud if you're interested in downloading the data. So Dr. Wang was interested in looking to see if telomeres were short in childhood cancer survivors and hypothesized that genotoxic therapies damaged telomeres so that they would be prematurely short, and that would increase potential for age-related disease and mortality. So in fact, telomere length is significantly shorter among survivors of childhood cancer than among non-cancer controls, and it's also associated with unfavorable health behavior, indicating that there's a possibility that we could do a lifestyle intervention to affect this molecular marker. Dr. Wang also looked at epigenetic age acceleration in survivors and controls. And he's reporting that epigenetic age acceleration, which is estimated from residuals from a linear regression of epigenetic age from methylation spots on CPG islands, against chronological age, and is associated with the steeper slope of the line in survivors when compared to the controls, suggesting that they age faster. Epigenetic age is higher in all diagnostic groups than in controls, with survivors of Hodgkin lymphoma experiencing the largest age acceleration. As with telomere length, epigenetic age acceleration was the greatest among survivors with the most unfavorable health behaviors. So as I showed earlier, low lean muscle mass and weakness are components of frailty, and sarcopenia is prevalent in the cohort, represented here by lean mass values lower than expected. Using the correlative genotype data, when we look at mitochondrial DNA copy number, a 1 standard deviation decrease increases the odds of sarcopenia by 42% in childhood cancer survivors. And interestingly, although I don't show these data on this slide, low mitochondrial DNA copy number is problematic for survivors with a mitochondrial DNA T to C transformation on MT204 in the D loop. Although cellular senescence is largely undetectable in younger populations, when we evaluated P16 in 4A mRNA expression in peripheral blood T lymphocytes in 59 survivors of childhood cancer, we found associations between expression and 2 potential markers of aging, walking speed and abnormal body composition. We also evaluated one marker of inflammation, high-sensitivity C-reactive protein, which was also associated with walking speed and abnormal body composition. So given all these evidence and all these potential targets, I'm going to review potential interventions to remediate frailty in survivors with multiple or specific deficits, with phenotypic frailty, or with evidence of molecular aging. This study with MPIs, Dr. Brinkman and Dr. Kroll, is called Sleep Well, and it's an e-health intervention for the late effects of childhood cancer with the primary aim of examining the efficacy of an e-health intervention for improving symptoms of insomnia among adult survivors of childhood cancer. Secondary aims are to determine whether treatment of insomnia will improve neurocognitive function, and to explore the mediating effects of improved neurocognitive function, emotional distress, and cardiovascular health on the association between insomnia symptoms and quality of life. The intervention parameters or intervention groups include sleeping healthy using the internet, which is an application called Shut-Eye, and it's a fully automated, interactive, tailored web-based program which incorporates cognitive behavioral therapy for insomnia and has personalized goal setting and graphical feedback based on reported symptoms. The content is metered out in 6 cores that are unlocked over a 9-week period. And then the control group gets a static website which provides information, and the material is available for 9 weeks. This is a randomized clinical trial, and obviously the patients can't be blinded to the intervention that they're getting. It has a 9-week intervention with 6 months of follow-up, and it will enroll 352 participants from the childhood cancer survivor study, and has some very comprehensive assessments that are done looking to see if this one intervention can improve multiple deficits that accumulate in our survivors over time. Another study by Drs. Brinkman and Kroll is called NeuroStim, and this study's primary aim is to evaluate the efficacy of home-based transcranial direct current stimulation paired with remote cognitive training on direct testing of executive function in survivors of ALL, and this is being done in the St. Jude Lifetime cohort. And it's based on data that 59% of adult survivors of childhood ALL are impaired on at least one direct test of executive function, independent of whether or not they received cranial radiation. And this picture shows here somebody who didn't get cranial radiation, who has poor myelin integrity in the frontal striatal tracts. So TDCS activates functional networks similar to those activated during cognitive training, and modulation of the cerebral cortex excitability by direct application of low-level electrical current to an anode electrode site. The current travels to a cathode electrode site, stimulating brain regions that lie in the path of the current flow. The anodal electrode is placed on the left DLPFC and cathode near the right temple. So they wear this little headband. And they do 2 remote stimulation sessions per week for 24 weeks. The active group gets the current, and the sham group gets the current for only 5 seconds, followed by no current flow. And they're monitored on a telehealth platform. So the study is done remotely. And then they have remote cognitive training paired with stimulation, and they play Lumosity brain training games focused on executive function skills. The study is going to enroll 102 participants, and this is double-blind, randomized, placebo-controlled, with 6-month trial of the home-based TDCS and remote cognitive training 2 days per week. Both of these studies were able to enroll people during the pandemic, which is great because they're done remotely. This study, Home Heart Health, is designed to test the efficacy of a telehealth-based intervention, which is individually tailored, aerobic and strength training to improve functional capacity as assessed by measures of exercise capacity, cardiac, pulmonary, musculoskeletal, and neurosensory function. This study is also done completely remotely, and we are also planning to measure changes in methylation profiles from baseline to week 20 in this study to see if our intervention affects this marker of aging. Now I'm going to show you.
Okay, Shayna, so we're going to get started with running in place again. Are you ready?
Ready.
3, 2, 1, go. The next one that we have is the wall push-up. And I remember I was talking about the wall getting a little easy. So we talked about trying to move down to a counter or a table. Right. Do you want to try a counter or a table today?
I do.
All right. And then Shane, I'm going to have you walk your feet back just a little bit more.
Okay.
All right. And then we're going to go down still in that straight line and back up.
Okay.
All right. You ready?
Ready.
We're going to try 15, okay?
Sounds good.
All right. Ready, set, go.
1, 2, 3.
And then for time-wise, we're going to go ahead and go on today to our next exercise, okay?
Okay.
So our next one, I'll have you grab the blue band. And then we're going to do the thing where we sit on it again and do the overhead press.
Okay.
So we're going to be at a 90-degree this way. So we don't want to be here. We're going to be out to the side, and then we'll push up and come back.
Okay.
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 We're going to do 10 of these. Ready?
Ready.
And go.
1, 2, 3, 4.
This study has a interface where the participants can see the exercises that they are supposed to do when they're not with the physiologist, and it can be delivered via a phone or a tablet or computer. And we provide the participants in our study with iPads so that they can watch the videos and do the exercises and record how they felt about the exercises in between their sessions with the physiologist. This completed intervention, protein supplementation and resistance training, was designed to remediate frailty in survivors with low lean muscle mass. The aims of this study were to evaluate the effects of 24 weeks of supervised resistance training, with or without protein supplementation, on muscle mass, strength, walking speed, self-reported exhaustion, and physical activity. We also evaluated the effects of this intervention on markers of cardiometabolic health. Participants were randomized to receive either resistance training and a placebo drink, or resistance training and a protein supplement. There were no differences in change in lean muscle mass between groups. However, both lean mass and strength increased over time. It appears that survivors were able to respond to the strength training no matter which group they were in, but the addition of the protein supplement did not enhance the intervention. There may be several reasons for this. One is I don't think that I used enough protein, but we'll have to do another study. Dr. Greg Armstrong has recently received funding for a pharmaceutical and nutraceutical study to address senescence in survivors that are frail. It's a 2-arm, either dasatinib plus quercetin or fisetin alone, randomized open-label intervention trial to improve the primary endpoints of cellular senescence and walking speed in survivors of childhood cancer who have a measurable senescent cell burden, determined at baseline and again at 60 days, compared with an individual arm. The objective of this study is to provide some initial evidence for efficacy in an efficient pilot open-label setting. If successful, these results will provide necessary preliminary data for a randomized placebo-controlled phase 2b trial of efficacy of these agents. Now I've talked about interventions to remediate frailty in survivors that are frail, but we don't want to wait until survivors are frail to do something about it. So in the next series of slides, I'm going to talk about potential interventions for soon after treatment and or during treatment that may prevent the onset of frailty. Rewards and Web-Based Physical Activity Intervention for Children with Cancer, or ALTE 1631, is a COG-wide study where our primary aim is to answer the question, does social interaction and rewards help improve fitness? Which we measure using the physiologic cost index. This measure of fitness is calculated from the 6-minute walk test completed during the functional assessment at each clinic visit. The study is approximately 18 months long, with 4 clinic visits every 6 months. The 6-month intervention period begins immediately after the first clinic visit, after the participant is randomized into one of 2 groups. The control participants see only their own activity. The rewards earned during the intervention are provided after the 6-month period ends. The intervention group sees their own activity as well as other intervention participants' activity, and the earned rewards are received during the intervention period. To be eligible for this study, participants need to be 8 to 15 years old at the time of enrollment, have a cancer diagnosis and be in remission, completed therapy in the past 12 months, and report less than 420 minutes of moderate to vigorous physical activity a week. They also have to be able to participate physically and have no impairments that would prevent them from using a computer. This study uses the Engage Move Band 5 for both groups. And this is a activity band that's used by the Special Olympics. And all participants can see their own data or activity rubrics on the app or on the computer. The intervention participants can also see others' activity through the platform's challenge feature. The leaderboard displays the participants' nicknames and how their activity compares to others, again, on the app or on the computer. A companion study called Step by Step is available through the Children's Oncology Group led by Nina Kaden-Loddick and Jason Mendoza for older survivors, and it employs individualized goal setting along with the physical activity tracker and social media communication for the intervention participants. The aims of this study are, the primary aim is to increase physical activity as assessed by accelerometry. The study also looks at biomarkers of cardiometabolic health and quality of life. Eligibility criteria of note is that you don't have to be on a COG therapeutic trial to enroll in this study. So anybody who's treated at a COG member institution can enroll, and this is for older children. A newly minted and planned study by Dr. Rachel Tillery Webster and Alicia Kunyan Batson is under review at NCI right now, and it targets caregivers as change agents to modify home environmental factors to improve young ALL survivors' sleep habits, physical activity, screen time, and dietary behaviors. And the aims are to evaluate this parent-targeted telehealth-delivered intervention. The plan is to enroll 334 caregivers of children diagnosed with ALL who are aged 4 to 12 years, who have no significant neurological or psychiatric issues that would preclude their participation. Here's a look at the study flow. Once families are consented, they'll complete a baseline assessment, which includes gold standard assessments of health behavior, cardiometabolic and neurobehavioral functioning, as well as factors that may impact intervention implementation. Participants will then be randomized to the Healthy Kids After Cancer intervention arm or the survivor education arm. Immediately following the intervention, participants will complete another assessment and one 12 months later. Caregivers will complete 3 sessions across each health behavior domain, and they'll be able to choose the order of the modules, and action plans will be tailored to the unique needs of the family while systematically delivering the intervention content. Educational control groups will receive the same number of contacts and the health links through COG that focus on survivorship-late effects. Those in the educational control condition will receive access to the intervention after the study is complete. This is a study recently completed at St. Jude for children with a medulloblastoma. It uses a hybrid approach, starting with in-person training for 6 weeks and then completion of an additional 4 weeks of the same training at home with parents. We enrolled 83 participants and are analyzing the data right now. This was done by the rehab department here at St. Jude while the children were here for their radiation therapy. The assessment was scheduled for 3 total hours, and they did it in 2 1.5-hour appointments. This was because this population fatigues kind of quickly. The assessment included a cardiopulmonary exercise test, which was performed on a cycle ergometer due to the balance problems these children have. And then we also measured resting energy expenditure, hand grip strength, flexibility, ankle range of motion, and some Brunick-Zatsaretsky tests, which is a test of motor performance. Participants were randomly assigned to group, and the intervention group participated in physical therapy 3 days a week for 60 minutes for a total of 6 weeks. 30 minutes of the session were spent in their target heart rate zone, which was 55 to 65% of heart rate reserve, calculated from their cardiopulmonary exercise test. They were allowed to do any functional activity. So I'm going to show you that here. They could keep their heart rate up.
Good job. Let's check your heart rate. All right, jog in place for me a little bit. Good. Oh, 2 feet. Good. Nice. Good. Get a little closer, 2 feet. A little closer. Good.
We also conducted a prehabilitation intervention for children with extremity sarcoma to determine if individuals diagnosed with a malignancy of the lower extremity could participate in a 10-week preoperative exercise regimen. We also wanted to look at the impact of the exercise training on function. Although we didn't enroll a lot of people, this was mostly a feasibility study. We compared these participants to historical controls who did not receive regularly scheduled PT prior to surgery. Our population was mostly male and reported their race as white. 2 of the 14 participants had an amputation and 11 had osteosarcoma. Their mean age at diagnosis was 13 years. The intervention was feasible, with 12 of 14 participants completing at least 50% of their PT appointments. Some of our evaluations were very difficult for the participants to do, and we learned a lot because of their tumor location and surgical status. The intervention group, when compared to historical controls, had better mobility 10 to 12 weeks post-surgery, demonstrating some initial efficacy. Thus, we have a randomized study planned for this population where the intervention will be delivered prior to local control and also in the weeks following local control. And this study is cleverly titled Seismic by Dr. Michael Bishop, who's leading it here, along with investigators at Emory and at MD Anderson. And this study aims to determine the efficacy of the remotely delivered combined prehabilitation and rehabilitation intervention on improving physical performance, patient-reported outcomes, and physical activity in pediatric and AYA patients with newly diagnosed sarcoma. We're also going to look at the effects on the tumor, and that's the investigator at MD Anderson, and then to evaluate the sustainability of improvement 1 year after local control is complete. The study includes both a pre-local control component and a post-local control component, both delivered remotely using the same mechanism being used in home heart health. This decreases participant burden as no travel is required to get to an institution to receive the exercise intervention. Finally, this exciting newly funded study by investigators at CHOP is an exercise with an NAD+ precursor supplementation for adolescent and young adults who receive stem cell transplant. And it's focused on skeletal muscle health along with exercise. And our institution's involvement is that my team will be delivering the exercise component of the intervention because, again, they're going to use our remote platform to do the exercise delivery. Patients will be enrolled from City of Hope and CHOP to start with. And this was interesting to me because of our finding that mitochondrial copy number and mitochondrial function appears to be impaired in these survivors because the NAD precursor helps NAD work to transfer electrons from one molecule to another and generate energy. So that's why we were really interested. So this study design is randomized, placebo-controlled, with a 2x2 factorial design, testing the effects of an NAD+ precursor and exercise on muscle mass and strength and VO2 max in stem cell transplant survivors. The primary outcome, again, is muscle strength, and there'll be a group that gets NR alone, NR plus exercise, placebo plus exercise, and placebo alone. And these are the intervention components. So this is the drug and matched placebo. And then the exercise intervention is 16 weeks long, and each remote session monitored via telehealth. There's a personalized exercise plan with a stationary bicycle and weights. I'm going to enroll 80 participants in order to complete data on 64. CHOP will enroll pediatric participants, and City of Hope will enroll both adults and pediatric participants. And they have to have a diagnosis of leukemia requiring transplant. 6 to 24 months from their transplant, and they'll enroll participants 15 to 30 years with a number of visits. So in summary, frailty is prevalent among childhood cancer survivors characterized by disease and deficit accumulation, or a physiologic phenotype, or molecular markers of aging. Interventions are underway to remediate frailty, and these also include targeting disease and deficit accumulation, targeting components of the physiologic phenotype, and also targeting molecular aging. And now, recently, we have interventions underway or planned to prevent frailty soon after therapy or during therapy for children with cancer. So I'd like to thank St. Jude for providing me with unparalleled opportunities to explore this area of research in childhood cancer survivors, especially my colleagues in the Department of Epidemiology and Cancer Control and the Cancer Control and Survivorship Program, and to the Basic Science and Computational Biology faculty for allowing me to collaborate with them. I'd also like to thank our survivors and their families for participating in all of our studies. And I'd also like to thank the external collaborators who have called me and included me and asked me to participate in this important research. And with that, I'm happy to take questions.
Thank you, Carrie. That was excellent. We have questions mounting in the chat box. I'll just remind folks, if you have questions, you can enter them in the chat box at any time, but we'll go ahead and start. Carrie, some of your earlier slides noted a difference in long-term functional status in men versus women who've had childhood cancer. Any thoughts about what's underpinning that?
Well, it could be hormonal, or it could be survival bias. As an epidemiologist, I sometimes think about survival bias because in healthy populations, men don't live as long as women. It also could be that those data were from the CCSS and their self-report data, and maybe women are more likely to admit that they're having a problem. Or maybe in our culture, females are less likely to engage in physical activity than men. I don't know if that's actually true anymore, but it used to be true. And so if you don't engage in physical activity, you lose function.
Okay, here's another comment from Dr. Armenian, City of Hope. Excellent paradigm-changing work. Looks like precision prevention is the best approach to remediating frailty, exercise intolerance, and this typically requires more advanced phenotyping. Can you comment on how centers without the same resources and facilities as we have at St. Jude can implement these phenotype-based interventions, and also speak about the longer-term sustainability of your interventions?
So I thank you for the question, Saro. I think that we can do some of this phenotyping remotely. In Home Heart Health, we actually do the assessment remotely. So the physiologists in our lab, get on Zoom, or on our platform is a HIPAA-compliant Zoom platform, and get on it and do the assessment with the participant, as you saw Nicole interacting who was doing the exercises, and we do the assessment remotely. So I think that we can do it that way. You can also, there's so much advanced technology for molecular markers now where you just have to, have them do a finger stick and drip blood on a blood card. In Home Heart Health, we're looking at methylation profiles in saliva. So I think that you can measure these things remotely, if you figure out how to do that. A frailty assessment isn't typically all that hard. I think we could use hand grip strength and walking speed, and I should probably do that evaluation or a data assessment to look and see if they're enough to characterize it in people. And again, we're lucky to have great resources to do this. And in terms of sustainability, we're trying to teach our participants who exercise to get a habit. So it takes about 11 repetitions of doing exercise on your own to get a habit. But I think that we also need to study what makes people not get a habit. I have a postdoc now who is really interested in why people who start to engage in exercise stop. And she has some theories, and we're going to see if we can figure that out in cancer survivors. Does it evoke some sort of an internal fear or internal bad feeling? So I think that we need to think about that. In terms of, drug-based interventions, just like any other drug-based intervention, not everybody takes their pills, but pills are easier. I've been trying to invent the exercise pill, but haven't figured that out yet.
Okay, here's another question. Are shortened telomeres due to the treatment journey or abnormal lifestyle in childhood cancer survivors?
So I think that they are associated with treatment radiation. So that's a treatment parameter, and then also with lifestyle. That doesn't explain everything. So possibly also due to having had cancer.
All right, here's another one. Is the data from the fitness study recorded with the fitness device, like an Apple Watch, or user input?
So it's recorded on the platform. Well, are you talking about the home-based? I don't know which fitness study, but is the COG fitness study it's recorded on a device on that Move band. But in home heart health, they're wearing a heart rate monitor, and then they have this platform or app that they're on, and they can log their exercises. Because when they click on the platform to follow the video, we know they've logged on, and we know that we think they did their exercises.
All right, here's one. Is frailty a one-time hit with a new, lower but parallel trajectory, or are our survivors on a steeper decline in frailty status compared to a non-cancer population?
Some measures it's a steeper decline, and for like epigenetic age acceleration, it's a steeper decline or steeper incline. And then for telomere length, it looks like it's parallel. For frailty over time, it looks like it's accelerated. And again, we had a substantial number of deaths in that cohort, which was a little scary.
Okay, here's another question that's addressing the issue of sustainability. To what extent do these interventions aim to improve physical activity and exercise, focus on long-term behavior changes in survivors? Do these interventions aim to improve physical activity, exercise, and survivors long after the intervention finishes, or just during the intervention period? I guess, what is your aim powered to do? If the aim is to change behavior in the long term, how do these interventions try and do this?
So the intervention, I'll talk about ALTE 1631. That intervention has a 2-year follow-up. So we're looking to see if physical activity is sustained over the 2 years. We allow them to keep the activity monitor device. And, we will test and see if they're still active 2 years after they start. In our home heart health intervention, we have a investigator from Washington University as part of the team whose expertise is dissemination and implementation science. And she's helping us work with the participants and the study team to figure out how we can make the exercise sustainable in the long term.
So it's particularly interesting that you have these prevention studies ongoing early in therapy. Can you address some of the challenges that you've had, especially considering kids may be more symptomatic with their cancer or their treatment? How is that? What's been your experience in implementing these types of studies, and what advice would you give to folks in this regard?
So I think that for each cancer population, we have to work closely with the clinical team to determine when's the best time and place to do the intervention. So for the kids with medulloblastoma, we worked with our oncology team here and determined that the best time would be during radiation therapy when they're actually not getting chemo. So although they feel fatigued, they're not, throwing up and completely decimated from the chemotherapy. And then we hope, and we're following this population long term, and obviously we'll see them in ACT clinic when they come over in 5 years. So we decided to do the intervention during radiation because we thought that they would tolerate it then. In the children with leukemia, we decided to do this intervention after therapy because we had previously, and I didn't show these data, we had tried an intervention during therapy to try and, with parents, caregivers, to try and get the kids to exercise during therapy. And it was, we didn't find a difference between groups. We got no signal, doing it in a way that would be disseminable. I think that if we did it in person and had the rehab staff engaged with them, we'd get an improvement, but I don't know how sustainable that is or how it's resource intense. So I think we have to think about the population. For kids with sarcoma, previously, when they first are diagnosed with their tumor, they get put in a brace if it's a lower extremity tumor, and they get taught how to crutch walk, and they might get a little home exercise program, but nobody's really done a prehab intervention with them. And when we tried it here, they were engaged and they liked it. And the kids who were engaged and liked it really had better long-term outcomes. And we looked at them 2 years later. So they seem to really engage in it and become resilient from interacting with the therapist and doing it. So we're hoping that giving everybody access, even if they live really rurally, which some of our patients here at St. Jude, don't live anywhere close to here, and they might live in a really rural community. By doing it remotely, we hope that we can make it so that they have access, and then it will be sustainable.
So this prehabilitation concept, it's relatively new to me. Is there a paradigm for this in adult diseases? I mean, why are we not doing this as a matter of routine?
Well, there's a paradigm in adult transplant that to do prehabilitation, and there's also a paradigm in the heart failure population to do prehabilitation to get people as strong as possible. And then in orthopedic surgery, if you're going to go have a total knee, they like you to get PT before, so that you go to PT before and you get strengthening exercises so that you recover faster. So yeah, I mean, I think that the prehabilitation is perfect for kids with sarcoma because they're not going to have their local control for 10 to 12 weeks after diagnosis. In other populations, prehabilitation wouldn't be possible because they start getting treated for their cancer right away, and there's not really, a time point called prehabilitation.
All right, we're at the top of the hour. Remember, Dr. Ness has agreed to stay on for an extended discussion, but I'd like to thank her formally as we close this part of the seminar for the excellent talk, and invite all of those of you who would like to stay for the continued discussion to hang on. Before I close, I'd like to give a shout out to next week's seminar that will feature Rising Stars of Cancer Research, a new component of the Science of Childhood Cancer series. It's designed to highlight impactful work being conducted by emerging leaders in cancer-related fields. Next week's theme is brain tumors, and will feature Dr. Mariella Philbin from the Dana-Farber Cancer Institute and the Boston Children's Cancer Blood and Blood Disorder. She'll discuss developmental pathways, plasticity, and novel treatment opportunities in pediatric high-grade brain tumors. And Dr. Giles Robinson from St. Jude Children's Research Hospital will discuss tailoring medulloblastoma therapy to fit the evolving molecular landscape. So thanks to everyone for participating. And again, Dr. Ness, for this excellent talk. And those of you who'd like to stay, there's still many questions for discussion, and we'll just continue on. All right, so Kiri, is there evidence for racial, ethnic disparities in frailty incidence? If so, do you envision tailored interventions that best meet the needs of specific at-risk populations and address some sociodemographic factors that may underlie frailty risk?
Yes, there are ethnic differences, which I really want to study some more. African American survivors have more frailty than do non-Hispanic whites. In St. Jude Life, we don't really have enough Hispanic participants to be able to determine whether or not there's a difference there yet. But I think the interventions would have to be tailored culturally to accommodate. And actually, we need to do some what I call PCORI-like work, where we engage the survivors and their families a priori to ask them, what would work for you to remediate this? This is what we've done for other populations. Now, we don't discriminate against enrolling people in our interventions right now. So we have African American and Hispanic survivors in the cohort who are participating, but there may be some differences in intervention. And then I think that some of my more basic science colleagues who are looking at genetics might help us determine, is this a genetic thing or is it not a genetic thing? This, does frailty differ by race?
What associations have been made with frailty and social determinants of health? Are there links there that impact risk?
Yeah. Low educational attainment,
SES, neighborhood effects, et cetera.
Neighborhood really affects body composition because access to grocery stores is problematic in low SES neighborhoods because they only have a Dollar General although now everything can be delivered, although there are neighborhoods, even in Memphis, where they won't deliver. But I think the interventions have to be different based on SES too. If you're going to say, I'll just use diet as an example. If you're going to target a dietary intervention, and we've shown that neighborhood SES affects your diet, and if your diet is worse, you're going to be more likely to have low lean muscle mass and obesity. That in a resource poor neighborhood, the intervention is going to be very different. It's not going to be behavioral. It's going to be figuring out how to get people access to resources first. And then in resource-rich neighborhoods where people also have low lean mass and obesity, but they don't have limited access, we're going to do more of a behavioral intervention. So I think we have to think about those things.
Is it possible to dissect out the types of therapies, for example, radiotherapy, chemo, or the combination, and the degree of frailty development, or the dependencies on the type of radiotherapy, such as dose, location, on development of frailty?
Well, we haven't done anything so refined as dose and location of radiation. I mean, location we've done, but I didn't show these data for the sake of time today, but we know that frailty is associated with cranial radiation, and it's also associated with abdominal pelvic radiation, probably because frailty is largely driven by low lean muscle mass. And if you irradiate the hormone producing organs of the body, or the hypothalamic pituitary axis, you're going to have abnormal growth during childhood, and you'll end up with low lean muscle mass. We also know that surgery to the thorax and surgery that removes part of the lungs is associated with frailty. That probably just really impacts health behavior. So we know that those are some things. And then, bizarrely enough, platinum, which may cause balance disorders that are subtle, because if both of your vestibular nerves get knocked out, you don't have vertigo. And so if you got treated with some high dose of carboplatin or a high dose of, or not even a high dose of cisplatin, and you have a balance problem, it might limit your physical activity because you don't feel confident moving.
So speaking of specific impairments and treatment-related impairments, what are the most common organ-based impairments that you see that are driving exercise impairments in your performance lab?
Endocrine, neurological, and cardiopulmonary. So people with neurological impairments, and that's typically because they're a hemiplegic or a paraplegic, or they have neuropathy that's bad, then that impacts frailty, primarily because the muscles require innervation to work, and if they don't get nerve supply, they also waste. And endocrine is associated with frailty, particularly in men who received pelvic radiation or testicular radiation. And then, people who have heart failure or pre-heart failure have frailty. Again, primarily because it's difficult for them to move, but it doesn't mean that they can't move. It just is more difficult.
Okay. Do you find, here's a specific question, are there any muscle groups that are more affected than others in survivors? Similarly, are there muscle groups that respond better than others to physical therapy?
Proximal muscle groups are easier to rehab than distal muscle groups in survivors, because you can exercise proximal muscle group with, more whole body movements, which are sometimes easier for people to do than very specific exercises.
All right, here's another comment. The opportunity to intervene on children in active therapy is tremendous. For the medulloblastoma studies, have you seen any results, or where do you anticipate you will see the greatest gains in that population?
Well, we're currently analyzing the data, and we are going to have great cardiopulmonary outcomes and hopefully great cognitive outcomes, and hopefully present our first abstract at ISPNO next year. Dr. Heather Conklin is collaborating with me on that study, and she'll probably present the abstract there.
All right, here's another question. Of all the interventions you mentioned, which ones have the highest potential for implementation and dissemination to larger populations of survivors in the United States and globally?
I think that the app-based interventions are the easiest to disseminate, but I don't think that they'll have the biggest results. And primarily because everybody's used to apps now. Now that everybody's been hit with a pandemic and are used to WebEx and Zoom, I think we can do exercise interventions remotely for people who have special needs. And I think of cancer survivors and kids with cancer as people with special, unique needs that where they require some sort of expertise, at least to get started. And I think we can deliver them remotely, and we're trying to deliver them remotely. And I think if we can deliver them remotely, it's game changing for survivors, because then they can get started on their exercise journey. I mean, I'm a believer in everybody needs an exercise journey, no matter who you are, even if you're only able to use your upper extremities to pedal a hand bike. And so I think that we can find everybody an exercise journey.
And how do you and your staff overcome perhaps fear of exercising, particularly with people who may have some impairments or disabilities related to their cancer or their treatment? How do you work with that group to initiate a plan? I mean, should there be a PT referral? How do you accomplish it in a clinical setting?
It would be great if every child who had a cancer diagnosis could have a PT referral. At least sometime, some of them get it. You know, everybody with a brain tumor. Here at St. Jude, everybody with leukemia and everybody with sarcoma probably gets a PT referral, because our docs are great and refer them to help them with function. But if we want to do an exercise referral, I think we need to refer these people to specialists whose specialty is exercise. So a PT who's got exercise expertise, or a physiologist who's certified in cancer rehab, because there's a certification. And they're trained to deal with cancer late effects or cancer effects. So they know what to do with somebody who has neuropathy, how to modify the exercise so that they can be successful. And I think that the fear factor is that I truly believe that once you exercise and you gain the skill, that takes away the fear. You might be fearful at first, and that's when you need supervision. And so when you're first fearful and you go and get supervised, and for anybody out there who's been to PT, I've been to lots of PT, you know, the PT helps you do the exercise, and then you figure out how to do it on your own. And once people gain confidence, I think that they have success, that then they can internalize the feeling of exercise. The people who work on my team and the rehab staff here are great, and they know how to motivate people.
And so is there a specific society or group that people who are attending should contact if they're trying to find a resource in their community for somebody who has cancer rehab experience?
Yeah, I mean, there's a cancer certified exercise specialist through the American College of Sports Medicine. And then there's the American Physical Therapy Association has an oncology subspecialty. And people are actually certified as oncology practitioners. Like, they're considered an oncology physical therapist.
Okay, that's great to know. Well, Carrie, we've addressed all the questions. Great talk, great discussion with the Q&A here. And we so appreciate learning from your expertise and look forward to future discussions with this very exciting research that you have ongoing. Thank you again. And thanks to all the attendees. You still have a big group who's been listening.
All right.
We'll see you next week for the next Science of Childhood Cancer. You guys have a great afternoon. Bye-bye. Thanks, Carrie.